crude schematic of the brain, the spinal cord, all those things. So what you can see is that here in yellow is your trigeminal nerve. Then you've got the trigeminal ganglion, which then gives off to your 3 branches. So this is cranial nerve 5. You've got your ophthalmic branch, your maxillary branch, and your mandibular branch. And it's the ophthalmic branch and the maxillary branch that provides innervation to the eye and the conjunctiva. So the virus will travel anterograde down the trigeminal nerve, and then will go and invade the structures that those nerves innervate. So also, it's uncommon, but I have seen it a couple of times now. Granted, my population that I see is biased, but this image on the bottom right, you can see is a cat that's got some excoriation kind of at the dorsal temporal aspect of the orbital rim. And that's actually a pretty classic sign if you have other clinical signs consistent with herpes. It'll be on the ipsilateral side of where the conjunctivitis and the chemosis is. And so because the trigeminal lives there, that you can get some herpetic cutaneous irritation infection. They'll actually just start itching on that one side. So just to kind of another thing to check in your box that, okay, maybe we are dealing with a herpetic infection. Also keep in mind that anything can cause a cat to stress out. Vet visits, vaccines, topical corticosteroids is the best way to cause a flare-up of a herpetic infection. And we'll kind of talk a little bit more about that a little bit later. But it's the gift that keeps on giving. So once they get herpes, they will have it forever.
If you look at them wrong, if a bird flies by the window,
if you move your chair
over,
yeah.
If you fed them at the wrong time.
Yes, we've all been there. So how do you diagnose this? So you can do a fluorescent antibody test, but it's really unreliable. You can also do serum antibody titers, but really it's only useful in cats that A, have never ever been exposed or are unvaccinated, but the titers can rise in a very unpredictable manner. So you can do serum antibody titers on a cat that has an active herpetic infection, but you don't see the convalescent titer, fourfold in titers. So those 2 tests, the fluorescent antibody and the serum antibody test, I would not waste your money on. The best way and the most sensitive way to actually detect for a herpes virus infection is viral isolation, where you actually do PCR. But you also have to keep in mind that clinically normal cats can have a positive PCR for viral isolation. So just because you test positive, if you don't actually have clinical signs associated with it, then it just says, okay, my cat has a herpetic herpes virus, but it doesn't mean that it's causing any clinical signs. So then you want to move on and think about doing a conjunctival scraping, which is actually something that I think in the books and what, you know, in an ideal world gold standard is that yes, every single cat that comes in with conjunctivitis, you should be doing a conjunctival scraping to rule out kind of other causes, and we'll talk about those other causes. However, I can honestly say that I've never done a conjunctival scraping to send off for virus isolation because based off of clinical signs, 9 times out of 10, it's going to be herpes. And so for the sake of finances, putting the cat through even more stress by doing a conjunctival scraping, you know, whatever the reason is, if it looks like it's a herpetic infection or everything is kind of ticking off the boxes that it's a herpetic infection, then I would just go with treatment for that. And then if it doesn't respond to treatment, then we start thinking about other things. So this is how you do a cytology. So I actually really like this. This is a cytobrush. They're very soft and they come in very pretty colors, but just topical proparacaine. Basically, what you're going to do is you're going to roll the brush in one direction on the conjunctiva, and then when you're on your slide, then you'll just roll it in the opposite direction. And then you'll stain it, and what you'll see is kind of this image that's on your right. So you can see epithelial cells, which are going to be your conjunctival epithelial cells, and those are these very large cells right here. And then you've got some neutrophils, which is also really common. And in this slide, you do not see any bacteria. I don't know, maybe that little bit right there. But other than that, it's a pretty just a neutrophilic inflammatory slide. And that's pretty classic for herpes. You're not necessarily going to see viruses. You're not going to see really anything that's going to be a slam dunk. But it basically tells you that, okay, what do I not see? And those are going to be our other differentials. Okay. So it's a pretty... like I said, I don't do this very often for conjunctival scraping specifically for herpes because oftentimes can get a pretty good idea that it's likely a herpetic infection, but this is cytology that you can do. So treatment. So you've got a couple.
Crystal,
Yes.
quick question. What are the brushes called again?
It's called a
cyto brush?
It's a cyto brush.
Yeah, okay.
Yeah, and I think that, I don't know the manufacturer's name or anything like that, but because there's those cyto brushes that they look like just very large bristles, like almost like spoolie type brushes. Those are just very harsh. These little cyto brushes, they're just very tiny, and they're just very, very soft. And so I find that there's a lot more patient compliance. And then you're also not going at them with this big, huge, long brush.
Yeah. And you're still swabbing even with an ulcer?
So that is conjunctiva. So yeah, so if there's a corneal ulcer, and we can kind of talk, that kind of muddies things a little bit.
Right.
But if you're doing a conjunctival scraping, you're just doing the conjunctiva.
Perfect.
Okay.
No more questions right now. Nothing's coming up.
Okay, perfect.
Thank you.
Okay, so treatment. Benign neglect in very, very mild cases. So let's say they just come in with just some blepharospasm and just a little bit of just kind of serous discharge, very, very mild conjunctivitis. Oftentimes those will regress on their own and they'll just spontaneously resolve. Sometimes just even getting them to the vet, putting eye drops, doing those things can cause more stress and make this actually worse. And so I'm also in the camp of kind of benign neglect to kind of see how things go. Obviously, if we have a very angry eye and we've got lots of conjunctivitis, they're holding the eye shut, they're miserable, they've got an ulcer on the eye, you don't want to do benign neglect, you need to treat this. So you've got a couple of options in terms of your antiviral medications. You've got topical and oral. Topicals are going to be your trifluridine, cidofovir, and idoxuridine. Trifluridine is the only actually commercially available ophthalmic antiviral medication, but you can get cidofovir and idoxuridine compounded from your local compounding pharmacy, and I actually prefer cidofovir out of all of those. Idoxuridine tends to sting a little bit more, and trifluridine I think is kind of cost prohibitive because now we can use compounding pharmacies. So cidofovir is my kind of go-to for a topical antiviral for two reasons. One is that I feel that the patients don't react as much to that as they do with idoxuridine. And two is dosing. So antiviral medications, especially these topical antiviral medications, are virostatic, they're not virucidal. So you're not actually killing the virus, you're just halting its ability to replicate. So for that reason, you have to give the medication very frequently. So idoxuridine, you actually have to give 4 to 6 times a day. So that's a lot to ask an owner to do. That's a lot to ask a cat to go through, especially if they're getting stressed out with drops. You're basically just making things worse. Cidofovir, on the other hand, at a 0.5 concentration, 0.5% concentration, you can give twice a day. You can give it twice a day, and it actually has better pain score and halting ability versus trifluridine. So cidofovir, you can't go wrong with that one. That one at least is a good one to try. Have I had to do idoxuridine because I couldn't control it with cidofovir? Yes, but cidofovir is a nice one because it's twice a day dosing. You can do oral famciclovir as well. So that I just kind of wrote a dose of a 90 mg per kg POBID dose. Keep that in mind because actually they've looked at studies where they've even dosed to like 1,500 milligrams per kg, and the cat did totally fine, but didn't necessarily prove to be any efficacious or not. So the dose is just kind of, that's what's out there. People need to have just kind of a starting point for a dose. So 90 mg per kg is a pretty safe one to start with. And then there's your oral lysine. And just, I know we've all heard about it. We've all even prescribed it and used it. Does anybody actually know the mechanism of action of lysine? Or what lysine is supposed to do, which is why people use it as an antiviral?
I'm waiting.
Mm-hmm.
I have a no. Someone says arginine.
Mm-hmm. That's getting close.
We're sniffing. We're sniffing it.
We're sniffing. What about arginine in particular? And if you don't know, I can always just tell the answer, but.
A virus requires arginine.
Yes. Yes.
That's
Whoever
what Liz
said
says.
that, gold
No, I'm
star.
not taking credit.
Oh.
That was not me. I'm reading.
Oh.
Good job, Liz.
Okay,
Virus
good job, Liz.
requires arginine.
Okay, yes. So yes, the thought is that the virus requires arginine to replicate. Arginine, if you guys remember, is an essential amino acid in cats. Cats have to get it from their diet. They can't synthesize it on their own. So the thought is that lysine will be a competitive inhibitor for the uptake of arginine. So if you look at this model, so in theory, it sounds like it would work. If you, let's say, drop the arginine levels down, so now the virus can't have arginine to use to replicate, then yeah, you would potentially help with the virus from being able to replicate. However, arginine is an essential amino acid, and they've looked at studies where they actually deplete arginine from cats' diets, and they do not do well. So the thought is, okay, I'm just going to dump a whole bunch of lysine, and then now the cell is just only going to be able to pick up lysine, but the lysine can't actually be incorporated for viral replication. So now then that virus is unhappy and not able to further replicate. The problem is that there's no dose that's known to be effective. There's a lot of literature out there that just say, okay, there was one. So I put a 500 milligrams per POBID because that's typically what most people start with. They did have cats that were on 10,000 milligrams BID, and it really didn't make that much of a difference when they were looking at viral load. So this image, so this is a paper from, I believe this is a 2015 paper from Vet Path. I'm not entirely sure actually, but it is a paper that looked at the efficacy of lysine supplementation for herpetic replication. So if you look at this image on the right, so you've got kind of the old assumed model and the evidence-based model. If you look at the image on the top, so you've got the cat's diet. The cat's diet's got arginine in it. The cell uses the arginine, and then now it's able to replicate and expose all of its little virulent proteins. And now the cat is sad because the cat has herpes. The thought is, okay, now we have the cat food. We add in a whole bunch of lysine. Now you can see in the little blood sample, there's less of the green square or green triangles. So there's less arginine. So now there's less arginine for the virus. And now the virus is unhappy because it can't replicate and expose all of its virulent proteins, but the cat's happy. Now, the evidence-based model, what actually happens is you give cat food, you add a bunch of lysine, and if you look here, the image in this blood sample and the amount of virulent, or I guess the amount of arginine that's in the cell is the same as it is in this image on the top. And that's because it doesn't actually show that if you give more lysine, that doesn't mean that the virus can't actually uptake arginine that's still there. So now you've got this virus that has a lot of different type of little virulent proteins that are on it, and it can still be as active as this virus up here. And now the cat is sad because the cat has herpes. So take it with a grain of salt. I've seen, if patients come to me and they're on lysine and the cat tolerates it and they're eating it okay and it makes the owners happy and it makes them feel better, I say go ahead and keep it. I'm not against using it. I just don't have any evidence to say that it actually works. Okay. So moving on to our next infectious, or I guess conjunctival disease, we've got Chlamydophila felis. So it's an obligate intracellular bacteria. It has a 3 to 5 day incubation period. Which is important to know because from the time they're exposed, there's a very actually small window from when you'd actually be able to get a sample to confirm if this is chlamydia. But we'll kind of talk about that a little bit later. It is zoonotic, so ew. I know a lot of people say, oh no, like, it may not be transmissible. It technically is, but the rate of transmission is very, very low. So just if you touch a cat or you have a cat in your clinic, just make sure you clean things as best as you can. But yes, it is zoonotic. So in the acute phase, you can see some conjunctival hyperemia, some chemosis. So the image on the top left up here, you can see very, very marked conjunctivitis and chemosis. It's very, very red and hyperemic. You can see some ocular discharge. They're painful, and it tends to be unilateral, and it also does not tend to be associated with corneal ulcers. So this tends to be just a conjunctival disease. Obviously, you can get secondary ulcers, but unlike the herpes, which we'll kind of talk a little bit about when we get down to talking about cornea, that herpes can cause corneal ulcers. Chlamydia does not as a primary pathophys. Diagnostic wise is cytology. So that's where you want to do your little cyto brush. And the timing of the sample is important. So you can actually only get visible intracellular bacteria from after day 3, and then it starts to disappear over 2 weeks. So there's kind of a critical time for you to get a sample. If you get your sample too early, you may not see anything. If you get your sample too late, you may not see anything. If you get it right in the sweet spot, you still may not see anything because you can't have false negatives. But that's kind of the time where if you're going to see them is going to be kind of 3 days after incubation period, or 3 days after inoculation, and then we'll start to taper down for 2 weeks. So this image on the bottom right is a cytology sample. Here you've got conjunctival epithelial cells, and you can see these very large basophilic intracytoplasmic lesions. So these are the chlamydia bacteria.
Dr. Marshall has a question really quick, Crystal.
Sure, yes.
So he said, in mature cats, is Chlamydophila more commonly bilateral compared to herpes?
That's a good question, and I don't know if I can say that that is true or not. I still tend to think of it as typically a very unilateral disease. But just like with anything, it can present as bilateral. So even if you have a bilateral patient or a patient that presents bilaterally, it can still be Chlamydophila. If it presents unilaterally, it can still be Chlamydophila.
Okay.
Crystal, can I give you sort of one impression that I see, and you can tell me if I'm full of it or not?
Yeah.
When I think of chlamydia, it's the cats that come in and their conjunctiva just looks like somebody blew it up with like a balloon, and they can hardly close their eyes.
Yep.
And that one, that's the first thing I go to on that. And I don't know that other things will get it that swollen like chlamydia. Is that true?
So there is one other thing that can get it to look as bad as chlamydia, but yes, if you tend to have a cat that you see, then you have eyes that look just, like you maybe can't even really see the eyeball itself because everything is just so swollen, looks like they lost like a boxing match, then yes, I tend to think more so chlamydia, because a herpetic conjunctivitis will typically not look like that. You can have, and we'll kind of talk about how everything kind of ties in together, because you can have a herpetic infection that can predispose you to secondary chlamydia infections or mycoplasma infections. So they can all kind of present or kind of be grouped a little bit together. But I agree with your clinical impression that, when you've got these cats that come in that they're just so swollen, that Chlamydophila has to be high in your list.
Thank you.
Mm-hmm. So you can take a sample and you can send it out for PCR and they can culture it. So that's another thing too, if you wanted to confirm that you're dealing with a Chlamydophila felis infection.
One more question.
Sure. Mm-hmm.
So somebody asked, will the discharge always be present and will it always be serous?
No, because that's a good question, but no. So if they have any secondary bacterial infection associated with it, that can make it look mucopurulent. You can always have a secondary bacterial infection. So like how I'd said with the herpes, that it's often very common that you get a secondary bacterial conjunctivitis as well. And so it does not always present with serious ocular discharge. But I don't know if you guys can appreciate that the way that this eye looks. Sorry, I just pointed at my screen and realized you guys can't see that. Okay, so here's my mouse. So if you look at this eye, can you guys all appreciate that this eye does not look the same as this eye?
Sure.
So it looks a little bit different. So the chlamydia you can get bacterial infections. I mean, even for all I know, if I didn't know anything about this cat and this cat came to me and it had swollen conjunctivitis like that, and I stained it and it had an ulcer and all these things, I mean, this could have been traumatic for all I know. Like maybe the cat was an outdoor cat and it got hit in the head by a ball or a dog or whatever. And we're dealing with a lot of conjunctival hyperemia associated with trauma. So it's just something to have on the back of your mind. Not everything is going to read like the textbook. But if you have a young, if you have a young cat, especially a cat that comes from like a shelter situation, types of things, and multiple cats in the house have eyes that kind of look like this, I mean, you have to have chlamydia on your list.
Yeah.
Excellent. If you guys do not have your microphones muted, if you could please do so, just double check. Thank you.
So in terms of treatment, so your erythromycin, your tetracyclines, your doxycycline, your azithromycin, give it 4 times a day for about 1 to 2 weeks past the resolution of clinical signs. Tetracyclines actually work the best for chlamydia. Now, tetracycline, when we think about that ophthalmically, that's usually our terramycin, which is oxytetracycline plus polymyxin B. And I'll touch a little bit on, the controversy of using those medications that have polymyxin B in them. But I tend to actually go for erythromycin, but I don't have any really rhyme or reason, aside from the fact that I find that because of the polymyxin B that's in there. But other than that, any of those medications can work as long as you're treating it for at least a couple weeks beyond resolution of clinical signs. So the image on the top is a before and after image. So the image on the top left is this image that has chlamydia, confirmed Chlamydophila felis, was treated, and then now the conjunctiva looks like this. So everything looks very, very quiet. This patient was, it was from a paper, and they treated with a tetracycline. So calicivirus. So Dr. Marshall, I don't know if you've seen eyes that look like this, and whether you see eyes that look like this and your gut is chlamydia, or is it potentially something different? But your feline calicivirus also has to be on your list as well. Granted, a lot of our patients are vaccinated, but it has to be on your list. It is a non-enveloped single-stranded RNA virus. And remember that it can also cause, the most common thing that when people think of calicivirus is kind of upper respiratory oral lesions. But, and it's very less frequently associated with conjunctivitis, but it can be. But the exact mechanism for how it's associated is not entirely understood. And that's the same with mycoplasma, which we'll talk about next. But it's just less frequently seen with conjunctivitis is the calicivirus. And when it does happen, it's very, very severe. Also, just kind of a little tidbit, don't forget about the polyarthritic cats as well, and think of calicivirus. I did have one cat when I did my internship down in Oregon that came in with polyarthropathy, oral ulcers, and conjunctivitis, and it was positive for calicivirus. So don't forget about those. So oftentimes, though, you don't need to treat it because it'll spontaneously resolve. So it can look really, really bad, and what you're treating for at that point is kind of comfort, any secondary bacterial infection, for this virus to kind of ride itself out. Some will be chronic shedders. They tend to live in the tonsillar crypts of your oropharyngeal tissue, and that's where you can actually, where you will culture and actually get potentially positive calicivirus. And remember, it's an RNA bacteria, so antivirals don't work. Antivirals only work for DNA, halting DNA replication. So there are no antiviral medications for a feline calicivirus.
Crystal?
Yes.
Had a question or a comment from Dr. Kuhl about sometimes treating chlamydia just systemically. Do you have good luck that way? Because in my experience, some of them, if they're really bad, are really, really painful, and it's just hard to get the meds in there, but systemic works pretty well. Do you find that as well?
I do, yep. And oral doxycycline works pretty well for chlamydia.
And for the calici on that, with that picture that you have there, it's kind of hard to tell in pictures, but do they seem to kind of have that more meaty appearance as opposed to the ballooning appearance? Yeah.
Yes. Yeah, it kind of just looks like, I don't even really know how to describe it, but yeah, it doesn't look like it's just swelling associated. Like, it just looks very meaty. That's a good word. Kind of a meaty, fleshy look to it.
Yeah. Okay.
Sorry, Katie, I was getting there.
Oh.
I wanted to interject at the right time.
I gotcha.
We have a quick question, Crystal. So with this patient, what are we doing? Like, are we giving pain meds? Is all we're doing pain meds? Any topical?
Yeah. So if you have any signs of secondary bacterial conjunctivitis, then topical antibiotics, pain medication, essentially supportive care, because these will resolve. There's no medication, antivirals won't work on this. Now, I say that because if, let's say, so technically antivirals should not work on this. However, what if this cat has an underlying also herpetic infection that's potentially exacerbating this and making this worse? Would a topical antiviral help with that? Yes. So if you get a patient that looks like this, are you wrong to start cidofovir? No. Are you hurting the cat if you give cidofovir? No. Unless they're very tender and and the owners are trying to put these drops in and it's painful and uncomfortable, then I almost would just let it be and do oral pain medication. So just like with anything in medicine, it's half of it is treating the patient and then half of it is also treating the owner. So what's going to be feasible?
Yeah. Do you, Dr. Marshall was asking if you're putting like any lubrication in there too. Like, are you doing Genteel or Opticare or anything for these guys, or just a pain? It's another thing to put in.
Yeah, I don't, but just because it's not wrong to do that. And I think the reasoning that people would do that is for fear of like desiccation and those types of things. So I don't think that it's wrong to do it. And maybe I should be doing it more often, but oftentimes I find that these cats are so uncomfortable that even just them trying to get medications in, it's causing more stress for the cat. But yeah, I think if you're going to use like an artificial tear medication, do an artificial tear ointment. Don't do a drop. I hate artificial tear drops because it lasts for maybe 30 seconds. So unless somebody is literally sitting there with a constant drip and doing this and this and this, and this goes with all of like any patient, dog and cat, and I'll get off of this soapbox, I do not like artificial tear drops. If you're gonna use it for the sole purpose of kind of lubrication, use an ointment. Unless the owners cannot do an ointment or the dog is not, or cat's not gonna tolerate it. But good questions.
Millie!
What's happening?
Look at, can you see Dr. Marshall? Oh no, you can't see.
No.
Sorry, Diane has Millie.
Oh.
And so I just said Millie
Oh.
and I got excited.
Oh. Sorry, I can't see anybody that's on here, so because I don't want to
scream. No, I forgot.
my
Diane like popped in and she has Millie, and I was like, the evil demon has arrived.
Sorry, Crystal, for distracting.
No worries. Okay, so oops. Sorry, there we go. So mycoplasma. So this is going to be the last bit of our conjunctival diseases. So it's a prokaryote. It's an opportunistic pathogen. So it's normally lives in the respiratory tract. Its role in conjunctivitis is a little unclear, but you often will see it because it's an opportunistic pathogen. You'll often see it in conjunction with another type of disease. So whether it's herpetic disease or chlamydia, that creates a perfect environment for mycoplasma to flourish. Diagnosis is going to be culture. PCR is going to be highly sensitive and specific. You can also this is where cytology comes in handy. And what you'll see is these large conjunctival epithelial cells, and then you'll see in the nucleus, you'll see all these little tiny basophilic, almost stipple looked like bacteria, and that's what it is. There's these small coxoid inclusions that are within the cytoplasm. And your treatment is pretty much kind of the same for chlamydia, and it's going to be your doxycycline, your tetracyclines, your erythromycin. So for that reason, if you think of the four kind of big things that you think of with conjunctivitis, you've got herpes, which you're going to be thinking about antiviral medications or any other type of secondary medications to treat for any type of secondary infection. Then you've got chlamydia, which will respond to your tetracyclines. You also have mycoplasma that will respond to your tetracyclines. And then you've got your calicivirus that won't respond to any antiviral medications. But if you have a secondary, let's say, mycoplasma infection, then that'll all treat with your doxycyclines or your tetracyclines. So for that reason, those erythromycin tends to be my go-to for feline conjunctivitis.
Got a couple of questions for you, Crystal.
Yes.
So one person asked, how often do you see ocular, I'm assuming, they said FCV, I'm assuming we're talking about calici, without oral ulceration, and how often does that severe chemosis combine with a need for more aggressive supportive care, like a feeding tube or anything like that? I guess kind of how severe.
Yeah. So I can honestly say that between my time here and my time over in Oregon, the only time I ever saw a confirmed calicivirus was a cat that had to be like hospitalized because it also had polyarthritis. So my population's a little bit biased because I don't necessarily see what you guys see every single day. I think that with the vaccinations that, we don't see a high prevalence of calicivirus. And so I can't comment on how often do you see that they're so bad that they need to be, have that supportive care. I would say it's a very, very small percentage. But yeah, that would be something that I don't necessarily commonly see.
Okay. And then just to confirm, Dr. Cool was asking, when you suspect calici, I think this is what you just said, when you suspect calici, systemic antivirals are not going to be effective.
Correct.
Yes. And then one other question, is Opticare Plus an okay product for lubrication?
I don't like it because it's a gel. It's not an ointment. And so you have to remember that when you think of medications, they can come in 3 basically different mediums, right? They can come in an aqueous solution, so a drop. It can come in a gel solution, and then it can come in an ointment solution, which is going to be kind of like your lanolin, like when you think of, Genteel Soothe PM ointment. That is my favorite ointment to use for lubrication because an ointment's going to last on the eye for a lot longer than a gel. A gel lasts maybe a little bit longer than a drop, but either way, I'm not saying that it's bad to use. I mean, people, we have it, we prescribe, we give optics care to people all the time. It's not like it's not a good one to use. You just have to dose it very frequently. So as long as you're able to do that and the cat's comfortable with using, you guys coming and dosing them at a much frequency versus an ointment, which you can give 2 to 3 times a day, then go for the gel. There's some patients that will not tolerate an ointment. So a gel and a drop is what you have to deal with, and that's fine. It's not like this is, you should not do this. I just find that clinically a gel does not last very long. A drop definitely does not last very long, and an ointment's going to last the longest.
Crystal, can I chime in for one thing from the GP perspective?
Yes.
When you were talking about calici, that I think a lot of us in GP are probably, they've got eye problems, but then we open their mouth and they've got ulcers on their palate and on their tongue and stuff like that. And then we're saying, oh, this cat has calici, and not sending them to you and waiting it out. So that might be why you're not seeing as many, but we're seeing it because of some different symptoms.
Yeah, and that's a good point. Like I said, my population that I see are very biased because you guys are the forefront, the people who are in general practice. You guys are the ones that they come to first. Nobody's really nobody even knows that an ophthalmologist exists until they actually need us. So so you guys are probably seeing it a lot more than I'm seeing it, and whether you guys are seeing it in terms of its severity, definitely, Dr. Marshall and Dr. Rongren and your general practitioners are going to have more insight on how they tend to see them clinically present. Because like I said, the only time I've ever actually clinically seen calicivirus was when I worked ER and had a cat that had oral ulcers, polyarthritis, and conjunctivitis as well. And we confirmed that it was calici. So I guess I saw it on the most extreme spectrum. Okay, any other questions before
I don't see anything else popping up so far.
Okay. Oops. Okay, so corneal diseases. So we're kind of going to shift gears away from conjunctival diseases, move over to corneal diseases. So we've got our herpetic keratitis, our sequestrums, and our eosinophilic keratitis. So herpes virus. So like we had talked about, it's probably the most common thing that you see is conjunctivitis, but the second most common manifestation of the herpes virus is going to be corneal ulceration. So these ulcerations can be dendritic. They can kind of have this almost like linear branching appearance to it, or they can be geographic, where you actually have kind of these larger ulcers. These ulcers are very painful. The majority of corneal nerves are actually in the superficial layer, which is why cats tend to be, or dog and cats tend to be more painful with superficial ulcers versus kind of these deep. Sometimes you have cats or dogs that come in that have like what seems like a hole in their eye and they're just walking around and acting fine. That's because there's no nerve endings when you're down that deep. So they tend to be very painful and uncomfortable. They can heal spontaneously. Or they can become indolent. And for those that aren't entirely sure what indolent is, most people think of indolent as kind of the first thing that comes to mind. Most people think of our boxer ulcers. It has different types of names, but essentially indolent is just a fancy word, just saying that it doesn't heal. So it can behave almost like an indolent or a boxer ulcer that you see in dogs, where if you were to take a Q-tip and actually debride it, you actually would have loose epithelium that start to peel off. Cats are not dogs, so do not try to grid them. And other soapbox, also do not try to grid dogs. Don't ever grid a dog. I have seen such horror stories of what happens. We can talk about it if we have time a little bit later about how to treat indolent ulcers in boxers, but there are other things that you can do that do not require gridding. So the main reason why you don't want to grid in a cat is because they are more likely to develop a sequestrum. So you can debride them to basically take off some of the loose epithelial cells, because the virus lives, technically, some of it can be in the epithelial. The thought is that if you kind of clean it off, that you might decrease the amount of viral load that's exposed. Either way, the treatment is going to be the exact same, like you're going to treat for a conjunctivitis. So your topical antivirals, possibly oral antivirals, have them on a topical antibiotic, and kind of treat supportively until these ulcers heal. The image on the top left, I don't know if you guys can really appreciate on this image, but you can see that the third eyelid is elevated, and kind of a dorsal temporal here. You can see there's just some conjunctivitis, looks like some chemosis, and then you've got kind of these very, very hazy, but they're actually very deep stromal vessels that you can see with pretty chronic ulcers. So chronic ulcers tend to have more of kind of like this deep, I think people term it like a ciliary flush, or like a feathered appearance, versus kind of just little kind of wiggly vascularizations that you see. So those are just kind of other things that you can see in the face of really chronic ulcers. And I should also mention, if you ever see a corneal vessel, that always means there's an active process that's going on. So if you just ever look at an eye, dog, or cat, and you see just some corneal vascularization, that always means that there's something active. So this is an example of, so the image on the right is a Persian. Here you can see that the stain uptake shows this kind of very large geographic ulcer. The image on your right here, you can kind of see those linear kind of branching here. Just almost looks like it's just starting to kind of branch. And oftentimes, I think by the time that you guys see them, or at least by the time we see them, they already look geographic, because these little dendritic appearances happen pretty early on with dendritic ulcers, and then they start to kind of coalesce and create more of a geographic appearance. Okay, so what do we do when we have a bacterial keratitis, and what antibiotic do we use? So let's say you've got a corneal ulcer and you're concerned about a secondary bacterial keratitis. Anytime there's an open wound, even if it's not infected, there's always a risk of it becoming infected. So this was a paper that was put out, I believe in 2011. No, I think this may have been 2011 in Veterinary Ophthalmology, looking at the most common bacterial isolate and antibiotic use. So in this study, they reviewed 81 medical records between the years of 2004 to 2017, and this was up over at Cornell. And they isolated bacteria, and the most common isolate that they got with bacterial keratitises was Staphylococcus species, which was about a little over than half of the population. And then they took those isolates and did a susceptibility test, and 100% of those responded to ofloxacin, followed then by your ciprofloxacin, and then kind of, if you look, kind of keeps going down, chloramphenicol, doxygenomycin, moxie, tobramycin, neomycin, blah, blah, blah. But they also have pretty high percentages, so 89%, 86%. Those antibiotics were still fine to use. Also keep in mind too that there can be some regional differences on strains of bacteria that are resistant to antibiotics. So like here it says 86% are still, the bacteria was still susceptible to tobramycin. Over on the West Coast, when I was down in Oregon, tobramycin, all the bacteria were resistant to tobramycin. So just keep that in mind, that when you read about these papers, that there can be some very regional differences. But my go-to for ulcers actually tends to be ofloxacin, your fluoroquinolones, but I do use tobramycin as well. And over here in the Midwest, that seems like we still have good coverage. So tobramycin is still a completely fine choice. Just the important thing to know is know exactly what you're treating and why you're treating it. So don't just grab whatever antibiotic is off your shelf if you don't know what it's treating, what is the most likely bacterial that you're going to be treating for, because that's just going to keep promoting antibiotic resistance, especially in ophthalmology world, because we have so little medications that are still left or available now that a lot of medications have also gone on back order.
I have a question for you, Crystal.
Yes.
This is a me question. So I had an ophthalmologist once tell me, it might have been back in Seattle when I was still at Island Cats, I was talking to somebody and they were saying that they tried to save ofloxacin for like their really nasty like infected ulcers, and then reach for something like a tobramycin or an erythromycin first. And I don't know how commonly people are culturing these in general practice. So I mean, I think a lot of these are not sure. But I had them say like, because I feel like a lot of times people used to throw ofloxacin at everything. It was like, oh, we have ofloxacin, it's available, we have a ton of it. It was just like everything gets ofloxacin. So then I got a little bit more nervous about using it. And I don't know, is that kind of what you're telling people as well? I know you said that's like your favorite choice, but are you grabbing that first, or you're grabbing it because you know that that's what you need?
So that's a good question. So I'm knowing it's okay. So the most common isolate, does anybody know, this is a quiz for everybody, what are the 3 most common isolates of bacterial keratitis, dog or cat? There's 3.
I'm watching the chat.
One of them is already named staph. So there's 2 more.
Yeah. Somebody said mycoplasma.
A good thought, but not the most common.
Is there Pasteurella in the eye just because they're cats?
There is, but also not one of the most common. Definitely Pasteurella and mycoplasma are on there, but that I would say is maybe like 4 and 5 or 6, but 1, 2, and 3. There should be 3.
Somebody said E. coli.
Yeah, E. coli.
It's not.
I know.
But I know. Everybody thinks it's E. coli because they lick their butts and blah, blah, blah. Everyone thinks that it's E. coli, but it's not.
Somebody said strep.
Yes. So staph, strep, Pseudomonas. Those are the top 3. So you have 2 gram positives and a gram negative, right? So when you think about doing broad spectrum antibiotics, you need to pick a broad spectrum antibiotic that's going to cover those, basically your gram positives, your gram negatives, and your most common isolates, which are going to be staph, strep, and Pseudomonas. So in response to your question, Kirsten, about ofloxacin, what I have found is that now this is just because I've been able to practice and see how things behave clinically, kind of West Coast, Washington, Oregon, and now Midwest, is that you do get very regional differences. So yes, I'm on the camp that tobramycin is probably still good to use. And a fluoroquinolone, yes, we're trying to save those more, but let's say that if you have an infected ulcer that has a gross infection, I would reach for ofloxacin over tobramycin. If you have, let's say, just a corneal ulcer that's not infected and you don't want it to become infected, tobramycin is totally fine. Because those are both are still going to get your gram positives and your gram negatives.
Yeah.
Okay. And yes, I don't necessarily, even in the ophthalmology world, I'm not culturing these left and right. You just have to base this off of data. There's actually, total side note, ARMOR, I think it's spelled ARMOR, is actually a database that they actually use in human ophthalmology, where they will do a big, almost kind of like Cochrane review, and they show which bacterial isolates are becoming more and more resistant to certain things. So just one thing I wish I'd paid more attention to while I was in vet school was bacteriology and pharmacology. But those things are important, and that's not just true with eyes. If you're treating with infections like systemic infections, think about what is it that's the most common isolate that you're going to be wanting to use an antibiotic, not just because, oh, I saw XY person use this, so I'm just going to use it too. Just kind of think about those things.
Okay. I had a comment from somebody saying that in the UK, chloramphenicol is kind of their go-to.
Yes. Yeah. I've actually, you're not the first person who has said that, because chloramphenicol used to be what everybody used way back when. And then they started being resistant. So then they started moving to these different antibiotics. And then now, because a lot of these bugs have not seen chloramphenicol almost seems like a new novel thing again. So you kind of get this like, a batch of bugs that have never seen chloramphenicol in a long time, and now you're using chloramphenicol and it's killing them. And that kind of happens with all antibiotics. So yeah, chloramphenicol, I have used chloramphenicol in cats.
Cool. Yeah, and it looks like our person who's logged on from Holland, which I love, says chloramphenicol, and then tetracyclines, and then our person who's logged on from India, you guys are so exciting, says tobramycin is a lot of times to start with. There was another question about those. So those are the most common isolates in cats, and then what about dogs? Is it the same or different? Good questions, you guys. Man.
Yes, good questions. But also keep in mind a grain of salt too, is that regional differences can vary. So there's lots of papers out there, that look at bacterial keratitises and isolates in both dog and cats. And you will even find that even within the United States, you have regional differences of what tends to be the most common isolate. So just be kind of aware of what bugs are normally around in your area, and that'll help direct you on what antibiotic choices seem like would be a good fit. All righty.
Thanks, Crystal.
I know. Hang in there, guys. I have no idea what time it is.
It is 11:58.
Okay, I'm almost done. Okay, so polymyxin B, to use or not to use. There is a paper that's out there from 2011 in the Journal of Feline Medical Medicine and Surgery journal that had looked at 61 cats over a period of 1993 to 2010, and found that most of them were young cats, and 87% of these cats were actually healthy. However, they had other things going on for a reason to be there at the vet. So whether it was they were getting vaccinated or they had other health issues that they needed to get addressed, when they were given a medication that had polymyxin B in it, so that's your Neopolybac, your Neopolygram, your terramycin, which has oxytetracycline and polymyxin B in it, that they found that about 56% of the cases they had an anaphylactic reaction to within 10 minutes of the drug application. Fortunately, over 80% of these cats survived. Very minimal death associated with those. Take this paper with a grain of salt as well, because they cannot prove causation versus correlation. It's just something that when they looked through, that was the common denominator between all of them. But some of these cats had other health issues. Some of these cats were on other medications. It could have been a vaccine anaphylaxis and not necessarily a polymyxin anaphylaxis. So take that with a grain of salt. But you will find camps of ophthalmologists that will not use polymyxin medications in a cat, or at least have a very serious discussion with them about giving that medication, and just let them know if they give it and they don't have a reaction, they're probably never going to have a reaction to it, and Neopolybac is totally fine. But it is something that you guys should be aware of. I personally do not use Neopolybac for that reason, because of polymyxin. Terramycin, I do use it when I know, like, if they've already come to me and they've already been on Neopolybac and they've been totally fine, and Neopolybac is not good against your staph strep, then I would, or if I've worried about a secondary conjunctivitis due to mycoplasma or chlamydia, I will put them on terramycin. But that's not my go-to, is to grab like a Neopolybac or something for a cat, because I get worried about the polymyxin. But I've never clinically seen it done. So this is all based off of like what is ingrained in me when you read the literature. And I'm sure tons of you guys are using Neopolybac or terramycin in cats and are not having a problem, but just want you guys to be aware that there is that information that's out there. But like I said, take it with a grain of salt, because they cannot prove causation versus correlation.
We have one more question. Do you always give antibiotics with a conjunctivitis? I was wondering if that was okay when thinking of antibiotic resistance.
I do. When there is a conjunctivitis, I do always give them an antibiotic. Yeah. I think that that's a fair thing to do, because oftentimes, like I said, so conjunctivitis just means inflammation, right? It doesn't mean that there's actually a bacterial component. If I see a bacterial keratitis or a bacterial keratoconjunctivitis, then yes, I will treat with antibiotics. Okay. Oh gosh, I'm so sorry if you guys have to leave. Okay, so I'll just be really quick about these kind of last few things. Sequestrum, brachycephalic breeds are going to be overrepresented. So think of your smush face cats, your Persians, your Himalayans. We tend to see them in those breeds, but you can see them in any breed. I've seen them in domestic short hairs. I just did a surgery on one and that was a domestic short hair. So just keep in mind, it can happen in every breed. It's thought to be possibly related to herpes. Nobody really knows. It's essentially corneal stromal necrosis. They've actually done where they've actually taken these sequestrums and sent them off for histopathology to see if they can figure out exactly what is this kind of dead tissue. And all they really find are just kind of necrotic tissue. Essentially, the brown pigment is not associated with melanin. Just a little tidbit. Everybody thinks that maybe there's melanin in there, but there really isn't. And the clinical appearance can vary. So it can kind of start out with just kind of a very faint amber hue. So kind of the more of like the image on your top right, where you kind of have this amber hue that's here, and then maybe a more densely pigmented. Sometimes it's just a little faint amber, or you can kind of have these very large, obstructive, sometimes the owners are like, I think there's a hole in the eye, or I just thought that was a pupil. That's like the most common thing I hear, is that people think that that's just their cat's pupil, but it's actually associated with the cornea. So treatment, you've got two options. You've got medical versus surgical. So medical options, because it's thought potentially related to an positive, that you have them on a topical antibiotic. And then you kind of almost wait and see. Sometimes what can happen with these sequestrum is that all these blood vessels will start to grow in, and they'll actually start to almost push the sequestrum off the eye. If that happens, that's actually good, because it means that the underlying stroma is actually regaining back to normal thickness, or relatively normal thickness. The problem is that anytime you've got a corneal ulcer, which most of these are subjected to, there's always a risk for infection. So you kind of always have to have them on an antibiotic. Two, if they still have an ulcer associated with their sequestrum, it's painful. So they're chronically always going to be in pain. And then three, it can take a really long time. I mean, it can take months to years for a sequestrum to come off on its own. I had one lady that came in that said, oh, I think my cat's eye fell out. I found it in the bed. And she like brought it in, and it was the sequestrum. Ew, but but just keep in mind that they can fall off. But did somebody say something?
No, I said, ew, I don't like that.
I know, yes. But the surgical option, would be something where you would probably refer. So essentially with surgery, we would do typically a penetrating keratoplasty, or do something and then put a graft on it if the underlying cornea is less than 50% to help with tectonic support. But oftentimes, if you are faced with a sequestrum, those are things that you can always just refer over to an ophthalmologist if you're not comfortable with managing those. And then this is the last bit that I'm going to talk about, eosinophilic keratitis. I don't know how many, I'd be interested to actually know how many of you guys in general practice see this and know what this is. But the clinical presentation can vary quite differently. It can start out with kind of these very dense vessels that you can kind of see right here in the limbus. But it has a very classic appearance. And I don't know, this is not the best picture, but I have pictures following up, that you can kind of see these little white plaques that are on the surface of the eye. That's classic, almost pathognomonic for an eosinophilic keratitis. It tends to start temporal, at the temporal limbus, and then kind of work its way axially. Diagnosis, you can always do a conjunctival scraping, or a corneal scraping. So I've actually just done topical proparacaine. I actually take a number 15 blade and use the edge that goes on the barred Parker handle, not the cutting edge, but the other edge, and basically just kind of lightly, just kind of scrape, get a little bit of cells, put it on the slide, look onto the slide, and sometimes see eosinophils. If you see eosinophils, it's pretty pathognomonic for this. If you don't see eosinophils, doesn't mean that it's not eosinophilic keratitis, just something that kind of helps confirm your diagnosis. Yeah, if you see these kind of little white plaque, cottage cheese like looking things on the eye, that's pretty pathognomonic for it. So this is just another slide that basically shows that'll show how things can look. So this image over here, you kind of see it starting at temporal limbus. You see kind of these little white fleshy plaques. Here, same situation. You've got maybe one little vessel that's kind of walking its way. This is a more dense, kind of up along the periphery. This is a pretty severe eosinophilic keratitis. You can see it's associated with also a lot of like corneal edema. Looks like we've got some positive fluorescein stain. This one looks pretty ugly too. And same with this one that's down here. But I don't know if you guys can all kind of appreciate, they all kind of have that look where it's just kind of like this white little chalky appearance and tends to start kind of temporal and lateral and then kind of work its way. So treatment, this is thought to be an immune response, and over an exaggerated immune response to maybe potentially underlying herpetic infection, or just an immune response where the body for some reason has now decided to attack its corneas, thinking that it's foreign. So you have to treat these with topical immunosuppressive medications. So your dexamethasone and your prednisolone acetate. Some people get very, very nervous, and I sometimes cringe, or I sometimes get nervous about starting a cat or any patient on steroids in the face of a corneal ulcer. However, you need to get, the only thing that's going to actually control the disease is actually steroids. So in this case, I know we're all harboring on like, don't ever put steroids in the face of an ulcer. I put an antibiotic on to treat the ulcer, but I also put them on a steroid because you need to get these corneas quiet. It's important to tell people it's lifelong treatment. I repeat, it's a lifelong treatment. So they sometimes I've been able to taper them down to a dose where I can get them off of it completely. But I can recall 2 that I've been able to do that and they've never had a flare up again. But oftentimes you get them off, then it comes right back, and it sometimes come back with a vengeance. So you kind of start them high, try to kick this in the butt, get the corneas to be quiet. Let's say now the corneas look, you do not see any signs of keratitis, and let's say you're down to like an every other day application. Maybe you can try a once a week application. Sometimes you can get it down to maybe once every 2 weeks application, and to try to keep these at bay. But it's important to know that just because they're like, oh, everything looks great, you can just stop everything. This will most likely come back. Like I said, it's very rare that I've seen them not come back. The role of this being an underlying herpetic infection with an exaggerated immune response is still unclear, but I do also start these guys on topical antivirals if I feel that there's an underlying herpetic component, and then you can always also refer these. Okay, now finally done. I'm so sorry that I'm over, but I appreciate those who've been able to stick around. This is my email. If you guys have any questions, if you guys need any, want to learn about any other things, I'm more than happy to share whatever knowledge I have, and also share resources that I have if you guys are more interested. I know eyeballs can be very scary, and people are very nervous about eyes and cats together, but just want you guys to know it's not that bad. They've got eyes, they've got 2. There we go.
You got the spare.
You got a spare. So, but yes, and then always if you're concerned, always reach out to your local ophthalmologists. We're all always really happy to help, because we know how scary eyeballs can be. So don't be afraid to ask any questions.
I've got a couple of questions if you want to
Yes.
take through. So first question is, for corneas that have keratitis with opacity and neovascularization, but stain negative, and why would you go to a scrape or cytology first, or treatment trial?
I probably would do a treatment trial, because you can get a corneal. So if you're stain negative, so you do not have any corneal ulceration, you've got keratitis, most likely this is probably a herpetic keratitis. Granted, I know that I'm a little biased because of how I see things. There's lots of things you can pick up on a microscope, like a slit lamp microscope, that I know most of you guys probably don't have. But herpetic keratitises tend to have a classic look where they actually have these very faint perilimbal vascularizations that kind of start all around the limbus. And then they can creep over to the cornea, but that's kind of where, if you start to see them there, you can have a corneal opacity associated with potentially some fibrosis, or just some scarring from a previous infection or a previous disease. And so oftentimes, if I have a patient that has that, where I've got some evidence of keratitis, stain negative, I have some corneal opacity, but I don't have any mucoid discharge or anything like that, I will start them on topical cidofovir, and oftentimes that will do the trick. Because it's oftentimes, like I said, 9 times out of 10, it's probably going to be a herpetic infection. The conjunctivitis is the most common manifestation that we see with herpes, but like I said, herpetic keratitises are the second most common. And so I would just go for an antiviral. I typically treat them for, have them start at maybe a 3 times a day for about 2 weeks, and drop it down to twice a day for about a week, then kind of once a day, and then kind of say, okay, keep it for another week or so after you start to see clinical signs resolve. And so usually I kind of have them on it for almost 3 weeks to a month. just to try to get this thing to quiet down. And then you can take them off of it. And then sometimes some cats will never get a flare up again. And then some cats do. But yeah.
Excellent. Then last, I think that covers it. The other question, had somebody whose sound cut out a little bit. She was just asking, what did you call the white chalky lesions that are pathognomonic for eosinophilic?
They're eosinophilic plaques.
Yeah, okay, that's what I thought. But
And it is not associated with the eosinophilic granuloma complex that I know that most of you guys in general practice see. So just because you see eosinophilic plaque, but you can think of it as being the underlying disease process is potentially being the same, right? The eosinophilic granuloma complex is potentially an underlying immune-mediated response. That's the same thing with the eyes. But with the complexes that you see on the body, typically you're giving oral doses of steroids. With eosinophilic keratitis, it's just a topical steroid is all that you really need.
Okay, I don't see any more questions popping up. I'm giving people a chance.
Yeah. Thank you, Crystal.
Yes.
Thanks, Crystal.
Yeah. That was really, really good.
I hope you guys enjoyed it. If any of you guys, like I said, have any questions that you guys have or think of, just shoot me an email, and I'm more than happy to get to them for you guys. And I hope everybody's staying safe and healthy wherever you are in the world. So
yeah.
All the thank yous. And someone says thank you from Pakistan.
Yeah.
Wow, that's so crazy. This is so exciting.
I love it.
So tomorrow we have ER with, I'm going to go and share my screen now.
So do I have to hit stop sharing?
I think I can take over.
Oh, okay.
I've got control. So I think, yeah, this is mine. So I'm going to go back now, even though that looks like yours. I'm going to go back and do the intro again because I was an idiot and I didn't hit record. You guys can't let me do this. Thank you, but we do have tomorrow, we have ER, if anybody's still out there. It's going to be really, really good with Mel and Paula. And Mel is relocating from one coast to the other today. So hopefully she makes it to Maine and is able to present. Otherwise, Paula gets to do the whole thing by herself. And I'm going to redo the intro. So everybody's welcome to leave now because it'll be the same stuff again. And we'll see you again tomorrow. Thanks, you guys.
Bye, everybody. I got to head out, but
bye, Crystal.
With you guys. I hope you guys learned something.
It was awesome.
Yay.
All right. Okay.
Bye.
Bye, Crystal.
Bye.
Okay, since I forgot to record the beginning, I'm going to just do it again here. Welcome to CAT class, and really, really excited today for today's lecture that you just saw. But I wanted to make sure that you guys could see on the recording, if anybody does, that we got the rest of the class this week goes as follows. Dr. Mel and Paula are doing tomorrow with ER and kind of what things you can handle in ER on your own, or that comes in as an emergency that you can handle in general practice, is kind of be what the focus is. It's their handles are at Vacation Vet and Beyond the White Coat. Friday is neuro for Dr. Lo Curtis. She'll be down in Texas, and her handle is @_Lo Curtis. She has a great Thrive DVM podcast that you should listen to. It's really uplifting. Oh, excuse me, did I say, yeah, that was Monday. Yeah. Tuesday, we have mentorship with Drs. Crocker and Rongren. Their handles at Dr. Tanasia Crocker and at vet _redefined. I'll be joining that as well, but that's going to be a good day for anybody that needs mentors now or in the future, and what to look for and how to know it when you get it. Wednesday and Thursday, we don't have anything lined up yet. Probably one of those days will be pain management, but I'm open to suggestions and for both guests as well as topics, and because we want to do what you want and what you'll get out of it. And then wrapping up next Friday, unless we keep going longer than that, is at the Derm Vet, Dr. Ashley. That is going to be really, really good. and join her on Instagram at the Derm Vet, 5 p.m. Pacific time. I don't know how many days she's going to be doing them, but she's been doing some happy hours there, just derm topics and a little potpourri, and enjoy that. So this is just a little promo for tomorrow. We got the at Vacation Vet and at Beyond.thewhitecoat. And if you didn't get your homework done on the YouTube that Dr. Mel has done on Comfortably Uncomfortable, a lot of stuff on what we go through as veterinarians. And if you are looking for a resource to share with those that friends of yours that don't really understand what we go through as vets, that is an awesome one. This is old. It's got a lot more than 40,000 views now. And so today, she says it was 10 years ago. I can't believe that it was 10 years ago, but maybe that we took this picture together.
Oh,
Here's Crystal.
I mean, I think that was my second year of vet school, so 7, 8 years ago.
Okay. So we've known each other for quite a while. And this I know is 6 or 7 years old, that I took from of Crystal and her sister, twin sister Christine, who's now close to a senior vet student at WSU here in the Cascades of Washington State. That's the two of those sisters working together down in Portland when Crystal was a opto intern. So excited to have her talk today. It was wonderful. She's a good friend and a great veterinarian and a stupendous ophthalmologist. So conjunctiva and corneal diseases. Thanks, you guys. It was a good day. I'm going to shut everybody down unless anybody has anything else they want to share. Open up the mics.
So I haven't seen anything else popping up. Oh, Rhiannon wanted to know, are you going to do your SAVMA?
Oh, yes. Oh, if that's Rhiannon, I was telling her about, this is you probably can't see it with the light. This is my cow butt picture that I got in Ithaca last week that I was telling her about.
Cow butt.
So, at the thrift store for $5. And yes, tomorrow, 1:45 Pacific so that can be kind of happy hour time frame for those on the East Coast. So what you need to know about cats that you're not going to learn in vet school talk is going to be here at this Zoom channel tomorrow, 1:45 Pacific. That was mostly set up for students in Calgary, but there's not too many of them, and I don't know where they're scattered to now, so we're going to do it at that time anyway for everyone. And I think that was the question. Yeah. Are you
going to record that? Somebody was asking if you're going to record that.
Well, I'm supposed to, but who knows if I'm going to or not. I'm trying to. Okay. Hi, Annie and family. How are you guys doing? You're unmuted now. Oh, you were.
Oh, we're good.
Good, good. Hanging in there. Hanging in there from Idaho.
You're so
Okay, good. Yeah, and that was awesome. So, okay, I'm going to stop sharing and end the meeting, stop recording and end the meeting. Thanks for joining, everybody. It was really, really good.
Thank you.
Bye-bye.
Bye, Annie. Bye, GM.